And here is the last thing, and here is where you need to be very careful. Really, our whole view of parenting has changed in the latter half of the 20th century. You know, people like Teresa Benedict and all kinds of other people who wrote specifically about the psychological meaning of parenting for the adults as a developmental phase, as an important arena of our psychological life as an adult, have brought to our attention this whole issue that parenting is something that's very meaningful and that we need to think about. And many, many of us will agree that our children have the unique capacity to give us the most intensely gratifying, joyous experiences, and also the most painful and heart-wrenching experiences. And I think there is profound truth in the saying that one can only be as happy as one's unhappiest child, right? And we work with people whose children are often unhappy. We have to understand that strain too, and I didn't want to go too much into also the impact of the child on the parent and the child's problems on the parent. But the stress of raising a child with problems is inconceivable to those of us who have been blessed to not know this personally. And no matter how much we work with these families, we will never really stand in their shoes. No one can stand in their shoes unless they're standing in those shoes, because they're too awful, these shoes, for us to imagine. So we have to remember that. But going back to what I said here, parenting brings up in us all of our stuck issues. Our child will touch upon and bring out all of those points in our own attachments, in our own histories, in our own lives that were not well enough resolved. They'll bring it out in us in order for us to be able to raise them well. These things will come out. And these things can be not easy to deal with. Now, this model is the model of individual therapy of an adult. It can also be the model of couples therapy. Depends, yes? But it means that here are two adults that come without their children to deal with their own stuff, and their stuff brings a lot of parenting issues to the discussion for a while, for part of the therapy, for all of the therapy. They might have even entered individual therapy or couples therapy because of parenting issues. But the parenting issues are not managing behavioral stuff with the child, but recognizing that one has some difficulty that is more profound. Now, we as therapists, all of these, this is good. If they went to individual therapy, that was their decision, we have no problem. Our problem begins, and that's why I wanted to show you all these different models, our problem begins when we get people who came to this, individual therapy with the child and they're only on the periphery, or to this guidance around specific issues with the child, and stuff comes out, stuff begins to come out that is really not about specific parenting skills, but really about more profound issues that have to do with their own history and so forth, and their own attachment styles. And there we have to be very careful, and there it is our job, again, our job, to recognize who's the patient, what's the contract that we made with these people. If our contract with them was that they are there only as peripheral figures in the treatment of the child, then we have to ask ourselves a further question. Do they come with a lot of openness to see their role here, and in which case we can maybe include some of that? Or do they come with an attitude of the professional fix my child with as little as possible touching me and as little as possible involving my stuff? Or the opposite, parents can come for guidance, for specific, parenting skills and developmental issues guidance, and then some of their stuff gets touched on, and they want us to help them with it, but we say to ourselves, wait a second, our contract with them was just for guidance. Yes? So we can't go there. And then we may find a person in a situation that their stuff got opened up and unprocessed. They leave our offices not helped, and things are actually worse for that family. Yes? Of course, we can also have more typically the father, but sometimes also the mother, whose stuff gets touched upon a little bit by mistake by the therapist, because it's right there, it came right up and stood in the middle of the session, and the father or the mother say, when you touch upon it, when you say something about it, they say, my contract with you was only for psychoeducational stuff and parenting skills. I don't want to be talking about my childhood. That's not what I came here about. So what I wanted to make clear to you is that the type and nature of involvement of the parents in the treatment with adolescents is not a trivial question. It is something that needs to be carefully thought through in terms of our theory about it. What do we think? Who's the patient? Who's the problem? What's our model? What is our contract with the different parties here? It needs to be clearly stated. And if we think that there is a need to change that contract and do something different, that too has to be stated. It cannot be just winged, because then we take a lot of risks. Okay, so that's for that. I wanted to speak about one more thing, which is actually in your handouts. Are we okay? Yeah? Can we go a little bit further here? Before we stop, and then I do my last piece. Okay. I wanted you to look at the article about transforming negative parent-adolescent interactions. I will not go over the whole thing with you, of course. You're perfectly welcome to do it yourselves. But I did want to look at it for a moment. They're talking about something that they call the shift intervention. Since, like we said, there is huge evidence, empirical evidence for the efficacy of family therapy with adolescents in reducing their likelihood of worse problems than the ones that they already have, reducing the likelihood of their problems worsening, and even improving problems that already started, like substance abuse and delinquency and other things. These are empirical findings that support the efficacy of family intervention that includes the parents in various ways. They're looking at these encounters where the adolescents are part of the work with the parents. They come in and there is intense conflict, of course, right? And our problem in engaging the family members is we need to make everybody feel heard. We need to make everybody feel that there is hope. If what happens in the session is such that everybody feels extremely angry, and the same interactions about, chores, usually it starts with these intense conflicts about chores that need to be done, mother thinks it needs to be more, daughter thinks the mother is too authoritative, and all kinds of friends, who to go with, who not to go with, curfews, all of these behavioral management issues that have to do with life in the family. If in the session the same occurs and the affect and the conflict go up and they're entrenched in the same type of interaction as at home, what we will very quickly get to is a point where everybody feels hopeless, and the chance of dropout from treatment is very high. The chance of engagement is very low. So we have to somehow break that pattern. And what they describe rather nicely is what they call the intervention shift, and what other people call all kinds of other things, but it's a nice way of looking at it. What they speak of is the impasse. Yeah, the impasse is this place where you get the parents and the adolescent yelling at each other, saying the same thing repetitively, and there's no listening and there's no communication, and you don't know what to do next. What they do is, if you look at the summary page, actually, they talk about their definition of impasse, and they say that impasse is defined as the unwillingness or inability of a parent and an adolescent to have a constructive conversation regarding the parent's expectations about daily household routines. For example, it's just one type of an impasse, but the inability to really have a constructive discussion. And a shift intervention, as they call it, is described in the article, and I think it's worthwhile looking at it. And it really is a way to resolve the impasse by completely shifting the focus. And if we are lucky, then that's what we manage to do. We manage to shift the focus on several levels. We manage to shift the focus from a behavioral management problem to what they call, or what you can call, it's actually quite kind of understandable, to core relational themes, right? So they give an example of Mrs. Jones and her daughter, and there's this conflict about household chores, and the child doesn't do it, and the mother says she doesn't do it, and the daughter doesn't want to do it, and thinks that the mother is, undermines the mother's authority. And at some point, when it goes like this, back and forth, the therapist says, what is standing in the way of discussing which chores are reasonable, or what's getting in the way? And the mother blurts out something like, she just won't let me be her mother, really speaking to a much deeper theme, which is her sense that her authority as a parent is undermined, that the daughter rejects her as a parent, as a mother. This is the kind of a thing that we want to get to. And I have to tell you, this is just a nice article that describes some of the typical, if you'll go there, I think the usefulness of this article is that it is not abstract, it is not conceptual, it is conceptual enough. I don't mean in any way to belittle it, but what it does is it gives you, I think, 7 or 8 particular themes that often, relational themes, that often underlie the parent's feeling in those impasses and in those very difficult relationships with adolescents, and some of the things that adolescents feel, and then it describes some of the ways in which a therapist can intervene. So in a sense, this article gives a very practical sort of roadmap, things to be aware of, things to be thinking about as you're going into these sessions with parents and adolescents. I wanted to say that this is, of course, just one way of looking at something we're all, from many directions, trying to do. I, for example, think it's useful also not just with adolescents, this whole idea of shifting the focus from an interaction that is locked in this negative, unconstructive way, to shift it from the behavioral manifestation that people are fighting about, why don't you do this and that? And I always want you to do, and you never want to do. To shift it from the behavioral to a deeper relational level, and to shift also as much as possible the affect from anger to softer affects, to feelings such as sadness, disappointment, hurt, longing, because it's much, much easier for us to be angry than it is to say that what fuels our anger is how hurt we feel, how disappointed we are, how much we longed for something else and we're not getting it. And that, in this particular case, speaking of adolescents and parents, is on both sides. Adolescents often feel a great longing for all of these things that we mentioned before, that the parents that come with them to our offices were not able to provide adequately. Issues in attachment. They all come with some ruptures in attachment, with parents who were either not there because they were working so hard, because they wanted so much to provide for the children, but they had to start from such a low point that they were never there. And when they were there, they were doing the dishes and cooking the meal for the next day and doing the laundry, and they couldn't be available emotionally, which is much, for example, if you like, it's often seen with survivor families. You know, adult children of survivors will talk about that. And that's a rupture in attachment. It's not a statement of evilness or meanness or judgmental statement about the parents as people or as parents. It's a statement about what certain circumstances do and how people cope with these very difficult circumstances. In other cases, it's ruptures in emotional attachment because people do come to the issue of parenting or to the phase of parenting in their lives with their own attachment difficulties, and they can't attach to their child. Or there's a lot of chaos in the family and people coming and going and fighting and violence, and that's all very scary for the child. Okay? So people come with that, and the child often really responds with their behavioral difficulties to these longings that they had for something else, for better parents, for being taken care of, which they don't get. Parents often come having been, taxed up to here by their adolescent difficult behavior and problems that add to their already complicated lives, and they feel very, very sad and hurt and disappointed about the parenting experience, which has not turned out to be what they wanted it to be. So we have to be aware of that. And what I wanted to mention before was that I personally trained with Hedy and Yumi Schleifer in their form. It's a version of the Imago dialogue, which does exactly the same with couples, where you try to do the same thing. You try to get through the impasse by taking it from the concrete behavioral management issues to the more to the deeper relational places and the softer affects, feelings, and emotions that fuel the resistance, the passive-aggressive behaviors, the anger in the relationship. And I'll tell you that one time in one of those training sessions, one of the first ones, a couple volunteered, and it was really one of the first training sessions, so everybody agreed that people will bring as an example a very minor incident. And so they brought a minor incident that causes trouble between them, which is that when the wife takes something from the refrigerator that's in a jar, she often doesn't close the jar properly. And then when the man comes to take it out, it falls and it breaks and there's a mess. Now, did you ever hear of something more minor and mundane and little than that? You would think, How much simis can you make from this already as a training example, right? Well, I'll just tell you that at the end of it, if you're good at what you do, and I have to say, Hedy and Yumi Schleifer are good at what they do. If you're good at what you do, you come perhaps to a place where the husband is able to share with his wife what he himself didn't know. He himself didn't know why it drives him so crazy and makes him feel so mad at her. But it comes to be that when he was young, his mother died. And for his mother, nice things in the house and keeping the house nice was very important. And he remembers this refrigerator, this brand new refrigerator, chrome refrigerator, which was then, very, very new and first of its kind that was in the house, and how he would sit in front of this beautiful, shiny chrome refrigerator and look at it. And it was clear that, to him, this was his mother. And keeping things nice and clean, especially the refrigerator, was very, very important to him. And when she repeatedly didn't do it, and things would spill and fall and make the refrigerator all dirty, to him, it was extremely painful. Okay, now, if you would like, you can look quickly through this article, and you will see some of the things that they mention. If you'd like, we can touch upon it briefly. If you look at some of the, page 5, some of the relational themes, if you want, we can read together the example of Mrs. Jones and her daughter, but I prefer, if you don't mind, to go to the next part of the presentation and leave more time for questions and discussion in the end. So let's just go to page 5, some of the parental issues that you should be expecting as the more underlying core relational themes. Parental helplessness, such as there is nothing I can do. Most parents express feeling inadequate and ineffective in managing their child. They often feared for their child's well-being, yet felt unable to protect them or control their behavior. Frequently, parents express their helplessness as anger. Okay? Parental fear of setting expectations. I don't want trouble. Many parents feared doing the very thing that enhances adolescent development, making maturity demands on their son or daughter. Parents assumed that they could do nothing to influence their son or daughter, and they simply had to wait until their child moved out or was arrested. These parents were in fact intimidated by their adolescents, as we said, and that leads often to parental abdication. I give up. Abdication shows up when a parent actively communicates his or her disinterest in continuing to exercise parental influence. Abdication is the last stop on a journey that ends in out-of-home placement. Together, these feelings accentuate further feelings of failure, accompany the parent's sense of inadequacy. Together, these feelings accentuate further hostility and abdication. And remember, one of the findings that I mentioned before, parental weak attachment, hostile parenting, all of these things are very high predictors, empirical, strong predictors of delinquency and substance abuse in adolescents. Adolescent entitlement, you can't tell me what to do. Many adolescents were unwilling or unable to negotiate for autonomy with their parents. With parents who generally had given up monitoring or structuring, these adolescents were accustomed to considerable independence, far greater than non-clinical adolescents. Many adolescents felt, therefore, entitled to their independence, not accountable to their parents' inconsistent rules. Adolescent rejection of parental authority and hierarchy. We are all equal. These adolescents strongly resisted the therapist's attempt to increase parental control. Yet they felt the parents showed authoritarian, okay? Authoritarian is very different than authoritative, right? Authoritarian is rigid and excessive use of one's power, where, you know, authoritative is a much more judicial and much more attuned use of one's power, attuned to the child's changing capacities and abilities. And if there's anything that adolescence is about, it's about the transformation of parent-child relationship from the parent being the all-authoritative figure to the parent and child finding some balance between autonomy and connectedness. And when the parent is authoritarian and has difficulty adjusting to these changes, we get problems, and the adolescents resent this mixture of authoritarianism and incompetence, and they often exploited this weakness. Adolescent helplessness, things will never get better. Parallel to what parents articulated, adolescents expressed their own despair and rebuffed the therapist's attempts to rekindle hope, which is really a defense against repeated hurt and disappointment, right? Adolescent negative perceptions, I can never get a break. Adolescents often felt that they were trying to cooperate, but their parents refused to recognize their efforts. They complained that parents were too restrictive in their attempts to reestablish control, or that their parents' negative set towards them would never change. Okay, these are some of the things we have to be aware of. Okay, I strongly recommend actually reading this article as opposed to saying I'll get to it, but I'll never, but never getting to it, because I think it's the kind of, I was happy to find it because I think it's the kind of article that, from my experience, people like getting, because we all can find a lot of extremely well-written, interesting theoretical articles, not so many that are very, very well-written practical articles. Okay, so now I think I'll take a 5-minute break, and after that, with your permission, I would like to literally walk through the evaluation of a patient. Okay? Yeah, if you don't mind bringing the questions up to Arlene so we can look through them.
Can everyone please take your seats? We're going to begin again. We won't have enough time unless we start right now. Our 5-minute break was, as you see, expanded by everybody. So, okay, great. Now we're going to start.
Thank you. Okay, so what I want to do with you is I want to go through a very good, I think, example of how we would like to evaluate an adolescent. And keep in mind, please, as best you can, some of the things that we talked about as we go through this evaluation. You know, when we talk about previous behaviors and risk factors and protective factors that have to do with the environment, with the type of parenting that the kid received, all of those things, keep it in mind. So here is the admission report for this kid. Reasons for admission: danger to self, yes. Danger to others, yes. Impaired reality testing, left blank, not seen. Symptomatology that significantly compromises functioning in areas such as work, school, family, yes. Lack of adequate response to prior outpatient treatment, yes. This is a patient admitted to inpatient involuntarily. And the specifications are: the patient transferred on PEC from Elmcrest Psychiatric Hospital for more intensive treatment of markedly aggressive, disorganized behavior with self-mutilation and homicidal ideation and plan towards parents. Homicidal ideation and plan towards parents. Excuse me just 1 second. I forgot to bring my copy on which I made some marks for myself as to what I want to address and what to skip. Okay, what I didn't show you was that there was a first page, which is simply the page with all kinds of course, data, age, who referred, with the race, the marital status, the religion, the highest level of education, the status, whether it's voluntary or not, all kinds of things like that, which I think are very important to ask about and to collect on one page, so anybody can open the chart, look at this page, and at least have some sense of what this patient is about. What kind of, is there a need for some cultural sensitivity? You know, it's important to know who we're about to meet, what status they're in, voluntary or mandatory, and so forth. Okay, so we go to the history of present illness. I will just read a few parts, of course. We will not go through the whole thing, but I want you to notice two things as we go along. I want you to notice the sections themselves. What did this initial admission evaluation include? And, of course, pay attention to some of the points we choose to highlight. So this is the continuation of the first hospitalization for this 17-year-old 12th grader who had been living with her mother in a project-type apartment and who is transferred from EPI for unremitting self-mutilative behaviors, marked emotional lability and homicidal ideation, intent and actions towards her parents, requiring a high degree of staff intervention and physical restraints, and thus far not responsive to psychotropic medication trials. The history was provided by records from Elmcrest Psychiatric Hospital as well as information gathered from her divorced parents during a pre-admission interview, which the patient did not attend. Okay, very important. Previous records, if possible, need to be looked at. We should not feel that they're not important and what we will see is good enough and we will anyway do a better job than anybody else. It's important to give it the respect and the time. And it's very important to include the parents in the interview, and it's very important, if possible, to include both parents, even if they're divorced and volatilely not speaking with each other, as in this case. Okay, I skip a bit. The patient reported that the patient had not had previous contact with mental health professionals until approximately November 1990. Pay attention, this was a year later. This is 91, June. During her senior year, however, the patient had become less involved in her studies. They suspect that she began abusing alcohol and perhaps marijuana and began to consort with a peer group that often included delinquents. Okay, we have here the onset of difficulties, at least noticed by the parents in her senior year, with falling down school performance, substance abuse, and delinquent peers. You remember, we did speak about the implications of that. There is a history by chart that the patient was raped by a boyfriend at age 15, i.e. approximately 2 years before this time, but this was not verified by parents. The parents, by the way, would have very little knowledge of that, since the mother, as you will hear about later, worked from 7 o'clock until late in the evening, was really not available. The kid was on her own, and the father was barely involved in the kid's life at all. The patient had been living with her mother, who by report is relatively high functioning. She was working 2 jobs at the time, carries a diagnosis of schizophrenia, and had been referred for outpatient treatment after many years previously of disorganized behavior and inability to care for her children, not just her daughter. The EPI chart refers to a street person type existence. I will actually say a little bit more about it from the later information we have about it, but these people, after the divorce, the mother was really very disorganized, and she and her son and Melissa lived on the street, suffering hunger on many occasions for quite a while at different times. Okay, I'm skipping to the next page. Okay. Am I at the, yeah, during her treatment at WYS, that's the previous hospital from which we got her, she began to verbalize suicidal ideation and plans, as well as plans to run away from her home and take care of herself. She began to exhibit impulsive behaviors and sudden changes in her appearance. Her grades, which had in previous years been mostly A's, plummeted to D's and F's as her school performance worsened during her senior year. Because of escalating intensity, mind you, there was no intervention by the school, having seen this A student go down to D's and F's. Because of escalating intensity of this ideation and, I will say WSY is not the hospital from which we got her. It's an outpatient, the Westerfield Youth Service Division, I forgot, to which she was referred, not by the school because of the plummeting grades all of a sudden from A's to D's and F's, but because a friend said that there was abuse in the house. So then they referred her to WSI. And in WSI, on outpatient basis, this is what we're talking about. She began to verbalize suicidal ideation and plans, as well as plans to run away from home and take care of herself. She began to exhibit impulsive behavior, sudden changes in appearance. Her grades had fallen. Okay, because of escalating intensity of this ideation, the suicidal ideation, and fear that she would act on her plans, she was referred for inpatient evaluation at EPI on March 91. It was noted that time that she manifested significant depressive symptomatology with irritability, decreased sleep at night, anhedonia, anergia, difficulty with concentration, decreased appetite, as well as recent reports of self-inflicted cuts on her arms prior to admission to EPI. Okay? We know that picture. It doesn't look good, right? When first admitted to EPI, that's the hospital that she was at before we got her, she presented primarily as depressed, irritable. Are you with me? Is it still there? Tell me when I need to change a page. When first admitted to EPI, she presented primarily as depressed, irritable, somewhat impulsive, and with labile mood. On initial psychological testing, she gave guarded, brief responses on queries but did not evidence gross psychotic thinking. Her IQ was 100, PIQ 98, and full scale 99 with relatively little inter-test scatter. Subjectively, her thinking was found to be vague, superficial, stereotypical, lacking in imagination, uniqueness, and originality. Please pay attention, okay, to this. This was associated with emotional constriction and marked limitation of responsiveness to affective stimuli. She exhibited marked, this is important because the tester already notices, or the person interpreting the test is noticing that while she appeared so blah, it might be not that she is so blah, but that it's a result of emotional constriction. She exhibits markedly diminished self-esteem as well as lack of motivation and or drive to perform. Look at, if you look at the chart that I gave you of internal and external developmental assets, having internal drive, motivation, all of those things is a developmental asset. So this kid has very poor external assets and somewhat problematic and lacking internal assets in some ways here. There was clear evidence for depressed mood and affect throughout. Her reality testing was found to be impaired, but not to the degree to indicate psychotic level impairment. Diagnostic considerations suggested by the protocol include a major depressive episode, dysthymia, substance abuse, alcohol and marijuana, as well as possibility of an identity disorder. Okay? We continue a little bit. During the 2.5 months at EPI, her clinical state deteriorated markedly, despite considerable efforts to forestall further regression. In addition to markedly irritable and labile mood, she began to display marked impulsivity. In particular, behaviors intended to injure or hurt herself, scratching her wrist, banging her head against the wall, using a comb to cut her skin, often requiring restraints and frequently the use of a safety coat. In somewhat more affectively charged situations, she would escalate to almost complete behavioral discontrol. Do I need to move on there? Okay. In addition, she has exhibited unrelenting suicidal ideation and plan, requiring continuous nursing supervision for almost 3 weeks. She has not been able to achieve any level of functioning that would allow leaving the main hospital building or going on pass with a friend or family member. In addition, the patient has verbalized intense feelings of rage towards her parents, in particular her mother. She has had numerous plans to kill her, and during a family session required physical intervention when she attempted to throw a chair at her mother. Okay. The admission goes on to include past psychiatric history. Okay, we start with the as you saw, the history of the present illness. Most important, go to reviewing past psychiatric history. There was no formal psychiatric history, we know, except for this episode, which started in about several months before. However, it should be noted that there is a history of long-standing dysphoria. Remember what we said about emotional problems in children that appear early, and especially depressive disorders, difficulty with peers throughout elementary school. She was teased and persecuted according to her mother. Turns out she actually was not just teased and persecuted, she was really persecuted, beaten and tortured because they were street people. They were poor. Her mother was disorganized, looked like a mental patient at certain times in life, and they just looked like a terrible scapegoating, inviting family. And an ambiguous history of early onset of alcohol and marijuana abuse per patient. We go on to baseline functioning. It's very, sorry. Okay. Did I go too far? Baseline functioning, it's very important to establish what was the baseline functioning of this person before the problem, the acute problem started. According to the mother, as little as 1 year ago, the patient was functioning quite well at school, achieving mostly A grades, and had a part-time job which she enjoyed. She had several friends, albeit somewhat superficial. She had begun dating around 14 and 15. Okay? And for all this time, between this functioning and the acute deterioration, nobody noticed. Okay. Alcohol history, dependence. Describe. According to EPI records, the patient reported, so notice, not only alcohol, sorry, thank you. Are we at the right place? Not only does she drink, does she not? A little bit more detail. When? How much? According to EPI records, the patient reported drinking 2 pints of alcohol per week, primarily Jack Daniels or Southern Comfort. It's important. What does she drink? How does she get it, by the way, also? But what does she drink? She reportedly began drinking at age 13. Mother, however, reports this is an exaggeration, and she suspects the patient has not used. Parents will, of course, especially after it turns out that things went south a lot, deny, not notice in an attempt to, protect themselves from feeling too badly or really not knowing. This is a parent who really wasn't very much there. Drug history, the patient reports use of, the level is abuse. The patient reported use of marijuana since age 13, but as above, this was denied by the mother, who suspects that this abuse also only began a little while ago. Okay, past medical surgical history, very important to include. There was essentially nothing. look at medical history, we look also at the patient, okay? We look at immunization, we look at allergies, drug sensitivities, psychoactive medication, relevant family psychiatric history and medical history. We have to ask about it. We know that these things are very, a little bit above, no, here, okay? Medical, here, you see that, here, relevant medical cycle, yeah. History of heavy alcohol abuse in father. There's this question of schizophrenia-like history in the mother, who denied the diagnosis during interview, but she was actually diagnosed schizophrenic patient in the past. History of dyslexia in the patient's brother, which immediately would mean that we have to also inquire into learning disabilities, dyslexia, and related conditions in our patient, except for the fact that this one was an A student until a very short while ago, which makes it highly unlikely. But we will still look into neurological issues. Developmental and family background. I want you to go to the second paragraph. The parents had a severely abusive relationship with reported episodes of physical abuse of the mother by the father. When the patient was approximately 3 years old, the mother took the children to a battered women's shelter and left her husband permanently. There's some strength there. Since then, he has visited the children approximately once every half year, inconsistently. The mother never remarried and experienced severe financial hardship during the early years of the divorce. That's when the child is between 3 and 9. The patient's brother was not able to complete his high school education, purportedly because of his dyslexia, but has since then attempted to finish by obtaining a GED. According to the mother, the patient and her brother are very close and have had frequent contact, including recently while the patient was at EPI. Strength. Okay. Okay, this may be an important resource in this exceedingly fragile, dysfunctional family system. According to the mother, the patient was vigorously teased and persecuted while she attended first through third grades for reasons that she could not elaborate. The patients, although not overtly school-phobic, often express fears about going to school. I wonder why. Since that time, her peer relations have been somewhat superficial and fleeting. According to the EPI records, the patient has dated and was purportedly raped by a boyfriend at age 15. She purportedly had recently broken up a relationship with a 22-year-old man prior to her admission. So there is rape, and there is relationships with delinquent peers, and there is a relationship with a 22-year-old man. She's 17. All of which are likely to be associated based on empirical findings with sexual behavior, with substance abuse, and delinquency. Okay, diagnoses. This is to show you the typical picture that we get with many of these children, with these adolescents, which is of co-occurring diagnoses and co-occurring behavioral risk factors. Okay? All right, bless you. Okay. Formulation of the treatment plan. We will only skip to, I'll go to the first line because it's an important one. This is a seriously ill young adolescent whose current clinical course has deteriorated during her almost 3 months treatment, despite aggressive, comprehensive treatment that includes concurrent administration of lithium and a tricyclic antidepressant. Okay? Although her initial presentation seems to have been most consistent with a major depressive type episode without overt psychotic features, superimposed on dysthymia, her current picture appears to reflect a more malignant clinical state. Going down, provisional treatment plan, safety, first of all. So we have maintained the patient in a highly structured and safe supervised setting as she exhibited marked lability of mood as well as dangerous acts against self as well as against others. Further assessment, okay, releases for the presence of reassess for the presence of a psychotic type illness, would consider retesting using Rorschach. Note that at the EPI she was tested 1 week after admission, so not to repeat exactly the same thing, but mentioned that the tricyclic antidepressants and regression induced by these 3 months may have exposed a psychotic underpinning which should be assessed now, even if they weren't seen in the previous assessment at EPI. The third point is medication, reconsideration of the medication regimen. 4, help the parents to regroup at least enough to sort of coordinate around issues pertaining to the girl. And strengths, pointing out strength, educational assessment, and early re-engagement, as this has traditionally been one of the patient's sources of strength and self-esteem, currently severely lacking in this senior in high school who had been about to graduate. Okay, this is the kid for whom I became the individual therapist in a context of a milieu therapy on an inpatient unit, the type of which rarely exists today, with a group of patients her age who had a ward group administrator. That's the person who sort of is the more authoritative person in charge of the coordination of the treatment of this person, a family therapist that dealt with the patient and the parents, myself as individual therapy person, and of course all the other components, recreational, work, study in a special school, and so forth. Going on to the psychological assessment, which was full, which now is not always available to us when we see a patient because it's expensive and it's time-consuming, but it's really an amazing resource, so I just want to mention it to you, not to underestimate what assessment, good assessment, can do, what good comprehensive psychological testing can tell us. Because at face value, looking at this kid, you saw what she looked like, right? Okay, diagnostic understanding. Did I skip too far? Diagnostic understanding? Yeah. Oh, wait a second. Introduction. Okay. Melissa presents as a moderately analytically depressed young woman. Analytically depressed, meaning that the basic themes of her depression, her core relational themes, have to do with relatedness and disappointment and hurt with relatedness, rather than with issues of self-worth per se and issues about self-identity. That is a very useful whole line of thinking developed by Sid Blatt, my mentor at Yale. Anybody who's a little bit interested can get a lot of articles that were published about it by him. So analytic depression, he claims that development is really sort of a tango between this spiral of two lines, analytic, which is our needs for relatedness and connectedness, and the line that has to do with self-definition, autonomy, self-worth, self-direction, and that they're both sort of interrelated and promote development reciprocally. Her depression was primarily analytic, so it's around issues of abandonment. Seems to experience considerable overwhelming sadness and rage related to unmet needs for nurturance and affection. She currently is functioning at a low borderline level with an underlying paranoid schizoid personality structure. Melissa experiences little, if any, control in her life and compensates for this by sealing off her intrapsychic world and constricting expression of her emotions. She's aided in this defensive strategy by avoiding affectively laden situations and deep interpersonal involvement. By maintaining a superficial level in her relationship, she's able to protect herself further from her own emotional responses and reduce vulnerability to potentially hurtful interactions with significant others. I will skip a little bit here. It says, something about her sense of lack of ability to impact upon others in the interpersonal arena, which is consistent with her neglect and abuse history, and also the heightened risk that she puts herself in further situations that compromise her safety. Okay, let's go to the next page. Tell me if I get there. Whereas Melissa's problematic behaviors, yes? Back one. Okay, whereas Melissa's problematic behaviors and dissociative experiences might suggest the presence of a formal thought disorder, there was no evidence whatsoever in the test data to support the hypothesis of an underlying psychotic process. The data must remain inconclusive, however, because of Melissa's constricted response style. Nevertheless, the convergence of test data indicate that Melissa's transient lapses from reality reflect a desperate effort to protect herself from being overwhelmed by excessive inner turmoil and psychic pain associated with chronic, intense anger and anaclitic longings. This is very important because, based on her behavior and based on her family history, it would be very easy to jump to the conclusion that this is a schizophreniform disorder or a disorder on the schizophreniform range. All right, internal assets in the bottom. I wish I could read some more to you, but internal assets. On a more positive note, Melissa has adequate and available internal resources to both organize her environment and control and direct her behavior in a meaningful way. However, she is impeded in these endeavors by her avoidance of emotional stimuli, which constricts her experience of and ability to interact with the world around her. Similarly, Melissa seems capable of psychological sophistication and self-reflection, but is unable to utilize these assets in a productive way. Okay, and what the, I will jump now because I see we don't have a lot of time, but go to the treatment implications. Mind you, these assets, had it not been for her response to the introjective tests, you'd never guess. All right? Treatment implications, tell me when we get there. Okay, look at that. Though she likely will rigidly oppose the treatment process, Melissa's testing behavior is a good example of her ability to respond when actively pursued, and it will be important for her treaters to bear this in mind and to do the same. Her propensity to become highly disorganized around affective experience will cause her to dissociate more and appear psychotic as the treatment process advances. When this happens, her treaters should be encouraged to maintain their pursuit and empathic confrontation of her feeling states. So not to be afraid that this is a schizophrenic patient disorganizing in front of your eyes, but to remain there, to pursue her real feeling states, which is what is disorganizing her in a defensive manner, rather than real fragmentation. Whereas Melissa's disorganized behavior may be interpreted as an indication that she should be left alone in the treatment process, to do so merely would affirm her illusion that she is worthless and deserving of rejection and abandonment, and would unwittingly collude with her defense of dissociating from her emotional life. Rather, at times of increasing disorganization, Melissa would benefit most from a calm but firm effort to return her to the present reality of the moment. Since we have only very little time, I will skip with you to a part of my 3 months, July, she was admitted end of June, end of June, end of July, there was a treatment review, because that's what we would like to do. I mean, I will not even go over the rest of the admission protocol with you, but you get the sense of the depth, of the treatment review. I will not go into the treatment review, which is something that occurs shortly after we started treating the patient. After about 2 months is a good time to sit down, either with ourselves or with the team that is involved in the treatment of the patient, and again, look at the information from everybody, gather it, think about it, see what we think after 2 months. It's very, very important before we sort of fall into just rolling from one week to the other without a clear sense of, okay, where are we at with this patient and where are we going to? So this was the treatment review at the end of July. I will not be able to go with you over all of it, but it covers, again, all of the pieces, the history, what we now see, how she is on the unit with her peers, how she is in all of the treatment modalities, how she is in individual therapy. And I will just share with you a little bit from my report of the individual therapy with her. Melissa. I've been meeting with Melissa 3 times per week since mid-June. That's 2 months now. Melissa comes to therapy without protest, although her face falls whenever I come to get her. And falls, I mean, this kid could sulk. She could sulk like nobody. She speaks repetitively and monotonously of the same symptoms and complaints which she presented to me on our first session. She feels confused. She doesn't know what she feels. She feels unreal. Everything feels unreal. She wants to hurt herself. She hopes she won't lose control. She speaks of frequent flashbacks and mood swings and says she cannot tolerate feeling like that. And this was repetitive and robotic and stereotyped. Melissa informed me that she has BPD, and told me relatively early in our sessions and without particular difficulty or affect. Yes? No? Am I too far? Melissa informed me that she has BPD, yes, and told me relatively early in our sessions and without particularly difficulty or much affect in any kind of a rape by former boyfriend which occurred when she was 15 years old. She also talks about she was telling me about the history, which you know. Then I say, Melissa seems to fade in and out. Do you have it? No. Okay. Up? Okay. Melissa seems to fade in and out of moderate dissociative states many times within any given session. She's aware of this phenomenon and refers to it as spacing out. She says she could always do it even as a child, but now it's worse. She repeatedly mentions her refusal to feel and to remember things, and describes her spacing out as a means of avoiding painful feelings and memories. However, she's equally disturbed and fearful of her dissociative states when she doesn't feel anything or feels dead or unreal, and of times when in these dissociative states she experiences flashbacks. We have to also remember, when we have the self-mutilating cutting kids, that we are aware in the literature of 2 ways of looking at it. One, that it is a self-harming, escape behavior from terrible things, so that not to feel the really horrible things, one focuses the pain on the cut, on the injury, and also, as in this case often, that it's a way of coming back from the dissociative state, actually, and grounding yourself in a very powerful physical experience in the here and now. And we can't assume. We have to talk to the kid to know what is happening for this individual kid. I say also, I'm continuously baffled. Do you have it? I'm continuously baffled by Melissa's robot-like mechanic behavior and by her stereotyped speech. She repeats the same phrases using a markedly constricted and undifferentiated number of expressions to describe her feelings. It is always anger, frustration, and confusion. They always were like that, undifferentiated. And most frequently it is, I don't know what I feel. Her facial expression is much like a mask. She never smiles and will very rarely allow even the most minimal eye contact to occur. She speaks in a low, monotonous voice, no matter how dreadful the content of her words, and with remarkably flat affect. I have great difficulty in sensing any budding of an interpersonal connection between us. It feels as if she speaks to an impersonal tape recorder.